faculty for today is Dr. Saswati Sinha. She is the Senior Consultant of Critical Care in AMRI Hospitals, Calcutta, and her area of interests are internal medicine and critical care.
So good evening, everyone. The topic for today, in fact, the topics for today are near drowning and thermal disorders. And what I have felt when I took my EDIC exams or the diploma exams or whatever, these are the situations which we are not very familiar with in our day-to-day critical care practice, but they are very important as far as clinical management as well as the exams go. So we would be going through all of these. So we start by drowning or near drowning. So basically there are several terminologies. They can be called as drowning, non-fatal drowning, or submersion injury. It's usually defined as a survival, at least temporarily, after suffocation by submersion in a liquid medium. And the loss of consciousness has to be there in order to classify it as near drowning. Now, since pulmonary complications may follow the aspiration of water without the loss of consciousness, the initial controversy was there that the loss of consciousness was mandatory. And if it is accompanied by pulmonary complications, then it adds to the diagnosis. Now, there are two different kinds of non-fatal drowning. The first is a wet non-fatal drowning, where the patient survives at least temporarily despite aspiration of fluid into the lungs, whereas the dry non-fatal drowning is, again, survival at least temporarily, and there has to be a period of asphyxia, and there's not much of aspiration of water into the lungs because there is a laryngospasm as soon as the patient falls or the victim falls into the water. So how does the AHA define the near drowning? So in 2010 resuscitation guidelines, drowning refers to a process which results in primary respiratory impairment from submersion or immersion in a liquid medium. So now it is called as, they recommend that it's drowning, and terms such as near drowning, secondary drowning should not be used. So it is now called as non-fatal drowning. So basically any survivor after submersion into a liquid medium can present with or without pulmonary complications, and that differentiates between wet drowning and dry non-fatal drowning. So the epidemiology is variable depending upon the location, and in low middle income countries, the fatality is very high because the rescue mechanisms are not in place. The victim might fall into the water and remain in the water without people coming to know about it. It may happen in the local ponds, in the local river, water bodies, and there is usually not many people who are available to rescue the victims. Now, the age is a bimodal distribution. It can happen in very young children, less than 5 years of age, who are inadequately supervised, usually in the swimming pools. Very small children can even drown in bathtubs or water bodies, especially water bodies towards the rural areas. And there are very small unsupervised children. They can fall into the water and become victim to that. The other age group is usually younger adults who probably are not very skilled in swimming, and they can fall into rivers, lakes, and beaches. Now, what are the risk factors? So inadequate adult supervision, like we said, inability to swim or overestimation of swimming capabilities, risk-taking behavior. There is a group of victims who are under the influence of alcohol and illicit drugs, especially in the Western world. They say that 50% of adult drowning deaths are believed to be alcohol related. There could be hypothermia, which can lead to rapid exhaustion or cardiac arrhythmia. So they really don't have the ability to even try and use whatever swimming skills or survival skills they have to swim back. If there is a concomitant trauma, stroke, or a myocardial infarction when they fall into the water body, if they have an underlying seizure disorder, or if the children have certain development or behavioral disorders, or if the victim falls into the water and has a primary cardiac arrhythmia, which could be triggered by hypothermia. And especially these are the victims who probably have an undiagnosed congenital prolonged QT syndrome. Or if somebody has hyperventilated prior to diving, this can decrease the CO2 quite a bit, but it also has an associated decrease in the partial pressure of oxygen, which can lead to cerebral hypoxia, loss of consciousness, and so the patient cannot come back to the shore. So what is the pathophysiology during when the person or the victim falls into the water? There is a period of panic, and so there is a loss of normal breathing pattern. So either they hold their breath or they have an air hunger and they struggle to stay above water. This can either lead to a lot of aspiration of water into the lungs or a laryngospasm, both of which can contribute to hypoxia, which ultimately contributes to organ dysfunction. And this is what governs the morbidity and mortality related to these immersion injuries. There used to be a differentiation which was emphasized in the past of saltwater versus freshwater drowning. But it is usually, it's very unusual for non-fatal drowning victims to aspirate more than 3 to 4 ml per kg of water. And so the distinction between salt and freshwater drowning is no longer considered important, because earlier there were definitions as to how much salt water or how much fresh water you have to aspirate in order for it to become fatal. But now the distinction is no longer significant. So what happens? There is a decreased lung compliance. There occurs VQ mismatch, intrapulmonary shunting, which eventually leads to hypoxia, and that causes diffuse organ dysfunction. It's important what is the temperature of the water into which the victim falls and whether the water is clean or contaminated, because both of which can affect patient outcomes, because the aspirating contaminated water or remaining submerged in contaminated water can again increase the risk of pulmonary complications and pneumonia. And as we can see, it has effects on different organ systems. So what happens in the pulmonary system? Once the victim falls into the water, the surfactant is washed out and it leads to non-cardiogenic pulmonary edema and ARDS. It may present as shortness of breath, crackles and wheezing, hypoxia. Imaging may be normal to localized perihilar or diffuse pulmonary edema. To start with, the X-ray may be completely normal and changes may evolve over a period of time, and you may need serial imaging in order to see the effects. As far as the neurologic system is concerned, because of hypoxia and ischemia, it may lead to cerebral edema. The ICP might elevate, and usually the ICP continues to rise progressively over the period of 24 hours, and the maximum ICP, which rises in the first 24 hours, can indicate the severity of the neurologic injury. And it's seen that in about 20% of the patients, even if they survive, they have a sustained neurological damage. So that becomes very important in prognosticating. As far as cardiovascular system goes, it's very common to have arrhythmias, which could be contributed from both the hypothermia, especially if the victim has fallen into cold water, or hypoxemia, or even staying inside the water for some time can lead to hypothermia. The initial arrhythmias could range from anything with sinus tachycardia, sinus bradycardia, or atrial fibrillation. And swimming, including diving, sometimes can usually normally our temperature is regulated between 36 to 37.5. And if the temperature is sustained above 40.5 or 105 degrees Fahrenheit, this is consistent with severe hyperthermia. And it's there can be different causes. The first is exertional heat illness or heat stroke. And the other hyperthermic conditions could be conditions like malignant hyperthermia or neuroleptic malignant syndrome. We come back to the same diagram where, again, if the body temperature is high, there are temperature sensitive receptors in the skin and hypothalamus, both of which activate mechanisms which increase heat loss in forms of sweating, vasodilatation, and basal metabolic rate, decreased BMR, which again reduces heat gain, as well as the behavioral methods by exposing body to the cold environment, wearing loose clothing, drinking cooler drinks. So all of these situations can help. Now methods how to improve heat loss would be evaporation is the most effective or the principal way of heat loss. However, if the situation is very humid, evaporation becomes ineffective, especially if your relative humidity is more than 75%. So how can hyperthermia cause problems? Hyperthermia increases, that is an increased core body temperature. It can cause decreased cerebral blood flow, causing hypothalamic damage. It can cause vascular endothelial damage. It can worsen the gut epithelial permeability. It can impair the immune system, cause effects on coagulation by increasing platelet aggregation and thrombosis. And the combination of endothelial damage, activation of the coagulation cascade, as well as activation or release of cytokines, all of these can lead to multi-organ dysfunction, despite the fact that there is no infection. Although there is fever, there might be organ dysfunction, but there may not be an actual infection over there. What are the two different, the classic hyperthermia usually which we face is heat stroke, which could be non-exertional and exertional. Exertional usually occurs in young, otherwise healthy individuals who engage in heavy exercise during periods of high ambient temperature. And there are non-exertional group. These are the elderly patients or with comorbidities who have other medical conditions which impair thermoregulation. So these group of patients, when they are exposed to an extremely hot environment and they do not have access to hydration or attempts at cooling, especially people who have cardiovascular comorbidities, neuropsychiatric illnesses, patients at extremes of age, or are on certain drugs which can impair heat loss. So these are the group of patients who have a non-exertional heat stroke. So which are the patients at risk? Patients at extremes of age, pregnant, obese patients, patients with poor physical condition, who have a lack of air conditioning, which can actually account for a lot of our population, especially in the rural setup, or not even in the urban setup, who do not have access to air conditioning or who have to work for prolonged hours in the extremes of heat. Patients who may be socially isolated, or certain medical conditions like diabetes, cardiovascular disease, or illicit drugs, or somebody who are on medications like anticholinergic drugs, anti-epileptics like topiramate, diuretics, or on thyroid hormones. All of these can interfere with temperature regulation. So clinical presentation, classic of heat stroke is usually temperature of greater than 105 plus CNS dysfunction in the setting of an environmental heat load. A lot of these patients have tachycardia, tachypnea, they may have a white pulse pressure, may be hypotensive, and usually land up with complications in the ICU with ARDS, DIC, acute kidney injury, hepatic injury, rhabdomyolysis, seizures, and hypoglycemia. Diagnosis, again, no surface temperature, core temperature monitoring is of crucial importance. Again, esophageal and rectal thermometers. In certain situations, you may need to do a toxicology screen to make sure that these were not under the effect of certain other drugs. Sometimes, if it is not fitting in to the classic scenario, you may need to do a CT scan, especially despite cooling if the patient does not regain consciousness, to rule out other causes of hyperthermia, especially patients with pontine hemorrhage may present with hyperthermia. Arterial blood gas analysis, and always look for rhabdomyolysis and its complications, because that is a very, very common problem, especially in hyperthermic patients. They are intravascularly volume depleted. They may have fallen unconscious, may have been lying down for prolonged periods of time with very high CPK, and may present with rhabdomyolysis. The differential diagnosis again would be infections, drug or toxin related, neurologic, like we were saying, environmental, endocrine, like a thyroid storm, pheochromocytoma, or oncologic. Sometimes malignancies like lymphoma and leukemia may present as hyperthermic states. As far as management goes, airway, breathing, and circulation, and just the opposite of hypothermia. So rapid cooling will be important, and look and treat for complications. As far as rapid cooling goes, the main crux lies in evaporative and convective techniques. What is done, especially in our scenario, you have to expose the patient completely, spray the patient with mist of lukewarm water. Don't use very cold water. If you use cold water, cold sponging is something which should not be done. As soon as you spray cold water, they will start shivering and they will retain more heat. So you should spray lukewarm water, and you have to have fans which have to be blowing on the patient over the moist skin. And again, as soon as it dries, you spray the patient back again. So avoid agitation and shivering. Should try, when you're cooling the patient, you should try and avoid shivering, because that will defeat the whole purpose. You might need to sedate the patient with small benzodiazepine boluses. Propofol, fentanyl have also been used in certain situations where you are not able to take care of the shivering. You may actually need to paralyze the patient for a period of time in order to make sure that you are able to properly sedate, paralyze, and surface cool the patient. And try and cool until the temperature, there is a little bit of controversy. Some say cool until 36. Some of them say you can stop at about 37 to 38 and do not need to cool any further. The other methods like immersion, use of ice packs are not very well tolerated, especially in the elderly population. They cannot tolerate this at all. In extreme cases like active internal rewarming, here you can do active cooling. So you can use cold pleural and peritoneal lavage, although this is usually not required and very invasive. You could use cooled oxygen, cooling blankets, IV fluids which can be cooled. Pharmacologic therapy is not of much benefit. Complications, again, it can affect all organ systems, respiratory dysfunction, arrhythmias and cardiac dysfunction, hypotension, may present as seizures, cerebral edema, rhabdomyolysis, AKI, hepatic injury, and DIC. Prognosis, again, depends how do you prognosticate, especially in severe non-exertional or classic heat stroke. It carries a very high mortality rate. It correlates with the degree of temperature elevation, the time to initiation of cooling measures, and the number of organ systems affected. So if a patient has come and has been lying down for hours and has been rescued, has been exposed to extreme of temperature, has a temperature of 107, is having a seizure, has rhabdomyolysis, has acute kidney injury, and is having DIC, this is a much worse patient to be able to tackle. Patients with non-exertional heat stroke generally have an increased susceptibility to heat, especially due to the age or underlying medical conditions. So thank you very much for your attention.
Yeah, thank you so much, ma'am, about this lecture. But just I wanted to ask about the iatrogenic hyperthermia that's related to administration of antipsychotic and the neuroleptic medications.
Yeah.
So for this kind of the algorithm or protocol for hyperthermia is the same like in heat stroke?
No, especially in malignant hyperthermia or neuroleptic malignant syndromes, you could use dantrolene. Not very widely available in our scenario, but yes, like in accidental hyperthermia, you really do not, medications do not play a very big role. But in neuroleptic malignant syndrome and malignant hyperthermia, in those cases, you have to try and avoid and identify the culprit drugs, and you can use dantrolene.
Yes, thank you, ma'am.
Okay, Dr. Sinha. So with that, we will conclude tonight's session. Thank you all for joining in.